Hello. Can you hear me well? Ophthalmologic findings. Do I have slides? Let me see. There we go. Ophthalmologic findings in patients with Lyme disease can present a serious diagnostic and therapeutic problem. The title of my talk should really be The Relationship of Borreliosis to Uveitis and Optic Neuritis in an Endemic Area. And in brackets, it should say, research is needed with re-evaluation in mind of our categories of serious ophthalmic inflammations, since there is clinical and pathologic evidence linking Lyme disease to such cases in endemic areas. I will present you here a handful of patients as an illustration of these clinical issues. The first patient is a 49-year-old white female seen for the first time very recently, last month, in my office. Her chief complaint was increasing floaters and difficulty reading. The floaters and reading trouble are common in Lyme disease patients. She was in good health prior to tick bite summer of 1991, at which time she had ECM rash, and she became seropositive by summer of 1992. She was under care of her internist. She was diagnosed with Lyme disease and treated in September of 92. She received 4 weeks of Rossetin, 3.5 months of Zitromax, and current medications, the only current medications, are urocolin and Zoloft, one for urinary retention, the other one for depression with partial to no response. On examination, her best-corrected visual acuity was 20/60 in the right eye and 20/30 in the left. And significant finding was in her retina. She had retinal vasculitis. Retinal vasculitis is hard to picture in a patient because often there is cloudiness in the vitreous. But this is why we have fluorescein angiography. And if you look at her vessels, you will see that they're irregular in diameter and that they show areas where the margin of the vessel wall is blurry. Here is another such area right here. Vasculitis is an inflammation of a blood vessel. It is an abnormal finding and it is the cause of this patient's visual problem. The patient was referred to retina specialist, and the retina specialist was inclined to consider this vasculitis as either a Lyme disease problem or an MS problem. He privately mentioned that he would consider Lyme disease more highly on the list if the patient hasn't had history of urinary retention trouble, which was new to the patient. I must tell you that she's not the only patient with Lyme disease who has had that problem. And it is very difficult to distinguish because there is a tremendous overlap. Patient was referred to an MS specialist at Columbia, and the spinal tap results are currently pending. I still don't have them. I spoke to the physicians yesterday, and it's still not available. My question as an ophthalmologist is, if patient's vision deteriorates further, will it be because of MS or because of borreliosis? Should I treat her with steroids or antibiotics? And I will leave you with that question as we go on and look at other cases. Case number 2 is a 55-year-old female, initially from England. She has been in this country for a long time. She first came to me in 1990 complaining of severe, persistent loss of vision. She used to work as a bookkeeper and therefore was very acutely aware of her visual abilities. She noticed fragmentation of her vision at first in the mornings, starting in 1987, and it would clear up by the afternoon. Later on, it would persist throughout the day. She also, at the same time, developed a whole series of systemic symptoms. She developed limb paresthesia. She had lightning sensation going down her spine into her lower extremities. She developed left facial numbness. She was seen in New York City and had MRI showing uveals, a non-specific white dot indicative of some inflammatory infectious process or disease process as seen by MRI. This was in May of 87. She was treated with oral prednisone because of her visual problem by another physician, and she was negative for Lyme disease serology in June of 87. In August of 87, she was admitted for IV steroid therapy with presumed diagnosis of MS. Her vision had in the interim deteriorated, and this is why this action was taken. This was done in New York City. She was admitted for a 5-day course, but signed out against medical advice after 3 days. And the reason, as she explains, is that after 3 days, she no longer could see the exit sign over her hospital room door that she was able to discern when she was first admitted. In November of 87, she was notified of positive FTA-ABS, which is a test for syphilis, and she was diagnosed as having spinal or neurologic syphilis. She was treated with intravenous penicillin, and she, during that therapy, experienced some changes in her vision, but not real true improvement. She switched her care to New Jersey, and in May of 88, she was diagnosed as having bilateral optic atrophy and positive Lyme serology. She was treated with ivermectin with complete resolution of all systemic symptoms. What remained was her poor vision. In January of 90, which was also prior to seeing me, she received another 6 weeks of ivermectin, and she started to be able to better see large objects and some colors. The reason I'm describing her vision in such a manner is because smell and acuity becomes pretty useless after vision drops past 2400. Shortly after stopping ivermectin therapy, her vision became dimmer. This is a subjective finding reported by the patient. On her examination in my office, her vision was miserable. It was finger counting in the right eye and light perception in the left. Her slit lamp exam and intraocular pressures were normal. Her fundoscopy was normal except for optic nerve heads, which is the portion of optic nerve you can see. The right optic nerve didn't look as bad, but the left matched her vision. It was pale and atrophic. Now, the impression that seems to pose itself is this Lyme disease which masquerades as syphilis or MS? Does this patient have Lyme and syphilis, Lyme and MS, or maybe all three? Maybe she's the unluckiest woman of all. The dilemma would be, in my mind, would the outcome be different if treatment were different? And is this patient safe without any antibiotic therapy? Because what happened to her eyes, could it happen to some other part of her body in the future? It's basically a system failure. Leaving you with that question, we go on to patient number 3. It's a 37-year-old woman with an interesting genetic background. She was first seen in my office last summer. Her chief complaint was eye pain and blurry vision, a very common complaint. She had been in good health until she had a tick bite with an ECM lesion in September of 88. She developed systemic symptoms, and after 10 months of systemic symptoms developed floaters as a complaint. She had general malaise, facial palsy, and sinus problems. On laboratory testing, she was shown to be HLA-B27 positive, which puts her in a category of arthritic, uveitic type of patients. She also had borderline positive Lyme serology, but was negative for all the other investigations regarding possible explanation for her uveitis. The most common association of HLA-B27 is psoriasis syndrome, and I will return to that in a minute. She received 4 weeks of oral tetracycline and became worse. She received 6 weeks of ivacaflin, at which time she noticed significant improvement in her vision, but developed fevers, persistent fevers of about 102. She was stopped then from her IV therapy and encouraged to do oral therapy instead. On 13, she did not do well. On her examination in my office, vision in the right eye was 20/60 and left eye 20/40. Slimmed examination showed conjunctival injection, and fundoscopy was once again the most revealing part of the exam. The viewing of her retina was through the vitreous debris from long-standing inflammation. The white blobs seen from accumulation of white cells in the peripheral vitreous are called snowballs. There was macular edema and panuveitis, meaning an all-engrossing uveitis or inflammation. There was gliosis, slight pallor of optic nerves, vascular sheathing, delayed venous filling, and left superior retinal atrophy, all due to long-standing inflammation. The cloudiness is due to the vitreous debris. This is the right eye and the left eye, but it's hard to see the swelling just looking this way. If you look at the fluorescein angiogram, you see the fluffy leakage and peripapillary leakage of the fluorescent dye. And if you look at her visual fields, you will see that they were greatly constricted. This is the Hunter method of taking visual field, different than the Goldman fields you saw yesterday. And this is the other eye. So, the patient was seen also in conjunction with a retina specialist. And the impression was that probably all her problems were caused by spirochetal infection and complicated by an immunologic dysfunction. This looked like an infectious process. Question is, what is the proper treatment in this patient? Antibiotics seem the likely candidate, but it is very difficult to treat this patient intravenously. And then, as the inflammation persists and doesn't abate, it is harder and harder to avoid steroids, and would this be beneficial or not is the question. This slide I threw in just to remind those of you who can't see it. If you haven't seen your ophthalmologist recently, it might be the time to make an appointment. This patient is another female patient. She's 37 years old, and she first consulted me in 1989 when she was a low Lyme disease patient, and just thought, for the sake of thoroughness, to have her eyes checked. And she was just a regular patient whose eye examination was completely normal on an annual basis. She, for the first time, really had a complaint in August of '92 when she thought she needed new glasses. She, at that time, reported that during the previous summer, she had an episode of leg vasculitis that was biopsied and examined by Dr. Berger on Long Island. He saw no borrelia by silver staining, and his report read that tissue changes were consistent with those seen in gonorrhea. Well, she didn't have gonorrhea. She was, in the past, treated 4 times with oral antibiotics for repeated bites and skin findings. She off and on has had arthralgia and fatigue throughout all this time. On her examination in August of '92, I couldn't prescribe her new glasses because I couldn't correct her vision in the right eye past 20/60, and in the left eye past 20/30. She used to be 20/20. I did a visual field, and I found enlarged blind spots that almost looked like glaucomatous, but her pressures were normal and constricted in both eyes. This is the left eye, and this was the right eye. Oops. I completed my examination, and upon looking at dilated exam and fundoscopy, I found white blood cells in her vitreous. I found retinal vasculitis and cystoid macular edema, all new. I referred her to a retinal specialist who said there was no pars planitis and that this was an infiltrative retinitis, uveitis, and vasculitis. I consulted with the head of retinal service at Neurocranium who confirmed those findings and agreed with the conclusions that this was an infectious process probably related to her Lyme disease. The patient was treated with ivermectin through my office for 6 weeks, beginning on October 22nd. 7 days later, she complained of right breast pain. Mind you, she was fine before I treated her, except for her vision. Right breast pain, stiff neck, and joint pain. We continued the treatment, and she improved by November 5th. Vision became 20/30, and fundoscopy revealed resolving retinal choroiditis. She was improving both subjectively and objectively. She was last seen this April, and vision is 20/20 in each eye again. There was minimal scarring in her retina, just as an evidence of previous inflammation. My dilemma here is, what would have happened if no antibiotics were used? What if steroids were used instead? Will it happen again? And was this a case of reactivation of Lyme disease? Was this an immunologic response, a delayed immunologic response, or was it a reinfection? I think there are more questions than answers. This is the same patient. This is her right optic nerve and her left fluorescein showing cystoid macular edema, the diffuse leakage. That central dark area should be clear and dark. There should be no dye seen, no fluorescent dye, but there is. And this is the other eye. And indeed there is leakage in both eyes. And one slide was inverted. The next case is a 51-year-old black female, first seen in April of '91 in my office. She had recurrent uveitis lasting a long time and secondary glaucoma with loss of vision. She had an 8-year-long history which started with waking up one Thanksgiving morning with a veil over her right eye. And I'd like you to remember this presentation when we talk about the next case. An ophthalmologist saw her on a holiday weekend and injected periocular steroids, which is an established form of treatment. Resolution was followed by many recurrences. Last 2 years, the other eye has become involved, and patient had suffered now for years with headaches, fatigue, and lower back pain. EKG reveals an old anteroseptal MI, and she has had a mastectomy because of a suspicious mammogram, but pathology revealed no cancer. I am adding this just for thoroughness. I do not know the significance. In February of '91, patient underwent surgical procedure to try to control the eye pressure from glaucoma because medications couldn't do the job. She doesn't recall any recent tick bites, but she had many in childhood, and she doubted seriously that she would have seen one, having seen the pictures of ECM and being very dark skinned. Her extensive workup was negative for sarcoid, and no, not rickets, but Behçet's, which is an inflammatory condition associated with inflammation and ulcerations in the mucosa of the oral cavity and the genital region. She did not have those. She was negative for findings of lupus and ankylosing spondylitis. Her vision was 20/60 in the right eye and 20/25 in the left. She had slight ptosis on the right, inflammation, and injection. Her eye pressures were somewhat elevated, and she was on all possible glaucoma medication. She She had vasculitis and sheathing in both eyes. She had postplanitis in one eye. She had optic nerve cupping of 90% in the right eye, which is a lot. 100% you are blind completely. And 10% in the left. It was interesting to note, reading her old records, that she lost vision prior to developing the cupping in her right eye. She had developed cataracts, and she had stilbitritis. Visually, both responses were inconclusive. It was difficult to confirm any diagnosis by standard methods. The question of Lyme has been raised by several physicians. Assisted by retinal specialists, we did a diagnostic vitrectomy for Lyme and sarcoid, looking for an etiologic agent of her problems. ACE levels are a measure of activity for sarcoid, and even though we obtained the levels, I questioned all throughout the country, and nobody could tell me that they were supportive of diagnosis of sarcoid at a level of 2.5 per liter as compared to her blood ACE levels. Ghost stain at Rocky Mountain Laboratories and vitreous and conjunctival tissue was positive, and MedPAT culture, which was done routinely, was positive for Streptococcus facialis, which was probably an accidental contaminant. Patient was treated with intravenous Herceptin, and her vision improved. She was then tried on Suprax, and she developed pseudomembranous colitis proven by culture to be C. difficile, and she had to stop treatment. I told you to remember the way of presentation in the previous patient. This patient here is 37 years old, and in February of 93 woke up one morning seeing blurry. She saw 3 eye specialists and was treated for conjunctivitis. Vision became worse and left eye became painful. In March of 93, she was found to be positive by Lyme serology. She traveled to Wilmer Eye Institute because one of her relatives worked there, and she was diagnosed as having bilateral exudative chorioretinal detachment due to Lyme disease. When she came to my office, the vision was 2100 in each eye, which is not very good. She really couldn't read. She had moderate follicular conjunctivitis, mild anterior uveitis, and early cataracts already as a result of her inflammation. In the left eye, there was still evidence of detachment of the macular zone, accounting for her poor vision. In the right eye, there was no such, but the vision was still 2100. There was resolving retinitis throughout her retina. Patient had, by the time she saw me, received 3 weeks of IV Herceptin with much improvement. Vision used to be light perception prior to Herceptin and 2100 at the end of Herceptin therapy. She was then placed on doxycycline without further improvement, and she was now seeking further help. She was on all the usual topical medications as given to such patients, and the bottom line should not read DC, Zithromax, and Suprax, but this was added at the time of her visit. The dilemma in this case is, as no improvement has occurred, even in that short time on all medications, will repeat therapy with intravenous medications for Lyme disease be necessary in this patient, or can it be avoided? We have decided to wait till mid-May to make that decision. This, I believe, might be the last case. It's a 31-year-old white woman who was first seen completely accidentally. Her daughter, who was about 6 or 7 years old, had an appointment, and mother complained about her eyes in the waiting room to my staff, and therefore arranged for an adjoining appointment. As far as the history of present illness at that time, there was none. Her past medical history was taken as usual and revealed a knee surgery, pelvic inflammatory disease, a cesarean section, urinary infection, and mastitis. Not uncommon. Her medications at the time of visit were birth control pills, and she was on amoxicillin pro-otitis, which was given to her by her daughter's pediatrician. She seemed to have a habit to kind of see the doctors her daughter was seeing. Her vision at the time of that visit was 20/25 in each eye, and examination completely normal. And I discharged her with instructions to return in a year. She returned a day or two later, said that the vision was blurrier and the right eye was painful. And indeed the vision was 20/40 in the right eye, 20/25 in the left. And puzzled by this, I did visual field. And the right visual field, and this is a screening test that I do when I don't expect to find anything really. It's not the most thorough way of testing, but there is scotomas, the areas where numbers appear rather than dots, meaning that brighter light had to be used in order to get the response. In the left eye, which was asymptomatic, there were no such findings. Patient returned the following morning and had a dilated exam again. And the right optic nerve head was slightly elevated with blurry margin, a first sign of swelling of the optic nerve. There were no spontaneous venous pulsations, which can be found in most patients, but don't have to be. However, they usually tend to be the present or absent in both eyes, depending on your genetics and your growth. She didn't have them in the right eye, but did in the left, suggesting there was a change taking place in her right eye. I followed her daily, and I didn't know what was wrong. On July 17, 1989, which is now maybe a week later, her vision in the right eye had dropped to hand motion. I knew she had optic neuritis. I did not know why. Her left eye was still 20/25 uncorrected. My impression was right retrobulbar optic neuritis, and now I question her in more detail regarding her history. It turns out that her daughter saw the pediatrician because of an ECM lesion and was also on amoxicillin for that reason. And I questioned the patient. The patient has been more fatigued and suffering with headaches, which were not her usual thing, for the last 3 months. I became suspicious of Lyme borreliosis. I treated the patient with ivaclopirin 2 grams and Solumedrol, hedging my bets, because when the vision drops to hand motion, you have very little time before you may lose the battle. And oral steroids have been proven to be detrimental last year by a large study on optic neuritis. So what I made sure of, though, was that clopidogrel was given 2 doses first before giving her a short course of IV steroids, trying to cover all fronts. And in 2 days, her vision improved from light perception to 2200, and in about a week or so, it was back to 20/30. I have a follow-up on this patient because the whole family are my patients, and her husband reported attacks of anxiety since the episode. He wasn't sure if she was still afraid of maybe losing her sight, she's a TV producer, or whether they were unrelated. They were having marital problems as a result of her anxiety attacks. They were seeing a marriage counselor. I last saw a patient, Betsy, in February of '89. Vision was 20/25. She had developed dry eye syndrome, and she felt well except for worsening headaches, which she didn't have time to address at that point in her life. And I will leave you with this, because these are the problems one has to deal with in an ophthalmologic practice in an endemic area for Lyme disease. Thank you. Thank you.
Okay, we have 2 more talks following up on the consensus conference from November. What we're going to do is take a break now. I'd like to be back here 5 till 3. And we'll start off with an announcement by Tom Forshner, and then we'll get right back into our other lecturers. So please be back in your seats at 5 till 3. The next 2 talks this afternoon are about the results of a meeting back in November 14th of '92 in New Jersey, where 30 to 50 doctors and researchers got together to try to come up with a consensus not only in what is Lyme, how do you diagnose Lyme, how do you treat Lyme, and the information at that point was collected and distributed to physicians for perusal, and today we have speakers who want to address what was discussed at that meeting. The first speaker is Dr. Ken Liegner. Ken is an internist and critical care doc, much special interest, as you heard yesterday, in not only being a patient advocate, but also in a lot of the neurologic aspects of Lyme in his presentation as in multiple sclerosis. Ken will be our first speaker. Thank you.
I'll just hold it. Thanks very much, Craig. We had a meeting, at Marriott in the Newark Airport, November 14th, and Karen was urging us to get something written up and out by the first of the year, 93, and a lot of us have been working on it, and some of us, like me, have been very have been remiss in doing what we should have done. Personally, I've had a lot of things on the fire recently, but I plan to really dedicate myself in the next month or so to really writing up referenced, at least my portion of it, so that we can get something together that is in shape for for submission for publication, hopefully for publication, that will be on record as reflecting the views of a substantial number of physicians who are frontline clinicians and researchers that can be, so to speak, state-of-the-art, and also can be a foil to other things that appear in the literature that we feel are not an accurate reflection of reality. I've never used this before. Let's see. Okay, I'm going to read this along with you. And these slides really were prepared by Karen Forshner, but they reflect what was put up on a bulletin board during this meeting in November, and reflects pretty much a consensus view of the people who were present. Let me just try to focus. Early localized disease, single EM at the bite site, no signs or symptoms of disseminated disease. This question of what qualifies as EM, obviously, if you wait long enough, you'll have a 3 or 4 or 5 or 6 or 7 or greater centimeter rash. But if you, as people get tuned into the disease and are very observant, and they have a tick bite and they watch it, or maybe they don't have a tick bite, but people are very sensitized to rashes that may occur on them, on their body, and on the bodies of their children if they live in a Lyme epidemic area. So it's clear that although you might not be able to be certain that a rash is an EM rash, rashes even, at a centimeter size, I mean, that may be EM, but it just hasn't been present long enough to attain a so-called diagnostic criteria. The other question is, we're thinking that you can make this distinction between early localized disease, and clinically it certainly behaves that way, because we know that most people who are appropriately treated early, it seems, really do not go on to later disease. So there certainly probably is a stage at which it really is localized in the skin, or if it is in the bloodstream, perhaps it hasn't sequestered and it still is susceptible to complete bacteriologic cure. And obviously it's much more likely to be localized disease if the patient does not have other constitutional symptoms. In contrast, you may have early disseminated disease where you have a rash, or maybe you don't have a rash, but you have a summer flu-like illness. And I think mention should be made, I think it was an article by Dinnerman on flu-like illness occurring where that is the manifestation of Lyme disease, a flu-like illness occurring in the summer. And I think that's a valuable contribution. In which those cases converted, and there was really nothing else to suggest Lyme except a non-specific flu-like illness. Fever, flu-like illness, lymphadenopathy, severe headache, and I think the work that Dr. Coyle has been doing and the work of others, including Garcia Manco, indicates that in a lot of these patients who have severe headache, it is not just a toxic manifestation of fever. It really does reflect dissemination of B. burgdorferi to the central nervous system, whether it's strictly meningocovascular or whether it's a true meningitis. There is bacterial involvement. Meningitis, cranial neuritis, radiculitis, Banwarts, spleen tenderness, although I don't know how useful a sign that is. I think you could argue whether that's, if you have stroke, whether that's really early. But multiple erythema, migraines, lesions, lymphocytoma, myalgias and arthralgias. Again, you may have, these are symptoms without signs sometimes. Ophthalmologic involvement. I think you can read that as well as I. And then late disseminated disease, where there are, again, profound constitutional symptoms. Fatigue, we know, is a very common manifestation of later Lyme disease. Chronic encephalomyelitis, demyelinating-like syndromes. Dr. Coyle has pointed out to me the difference in true demyelination, which you may see in true multiple sclerosis, versus demyelinating-like syndromes, where you may see UBOs on an MRI, but very often you don't see the presence of myelin basic protein. And in fact, in the patients that I've studied who I thought were misdiagnosed as having multiple sclerosis and who I thought really had Lyme, very few, if any, of those people had myelin basic protein in their spinal fluid. Then there are axonal polyneuropathies and cognitive and behavioral changes. Ophthalmologic optic atrophy, which you could argue is whether that's neurologic or ophthalmologic, ACA, and varieties of cardiac involvement. Myositis, skeletal involvement, true arthritis, synovitis. I don't know if hepatitis per se is mentioned, but certainly borrelial hepatitis is very common. Okay, then we establish a category of refractory disease, persisting signs and symptoms responsive to additional therapy, and I think that means that's implied additional antibiotic therapy. And the criteria for responsiveness are clinical improvement, development of a Yarish-Herxheimer-like effect, which is a clue that you may be dealing with active infection. Sometimes it can be difficult to dissect out whether a person is having a true adverse reaction to a particular drug or true drug toxicity versus whether what is going on is a Yarish-Herxheimer-like reaction. And that just requires careful study of the patient to try to decide what's going on. And then the other thing is whenever it is that you decide to stop treating with antibiotics, to see whether the condition deteriorates, which is from which you may infer that you have been dealing with suppressing an active infection by treatment. And then there's a comment that if one is not doing well on a particular regimen, that it may be reasonable to try a different antibiotic or even a combination of antibiotics. Okay, and then all of us who were there agreed that we do have patients who really do not seem to respond to any further antibiotic therapy. I have had patients like that, and I'm sure others have had patients like that. Of course, I think it's important to reassess the diagnosis. Is Lyme disease the correct diagnosis? And that's been well pointed out by Dr. Steer to the nth degree. But on the other hand, we have patients who really, really and truly did have Lyme disease or do have Lyme disease, but they don't seem to respond in any way to any kind of antibiotic regimen, and I think it's reasonable to infer that you may no longer be dealing with an active infection, and you may be dealing with something that is strictly immunologic or reactive in some way, and I think that that's real. I think that is a real phenomena, and there certainly are immunologic phenomena that occur in the wake of Lyme disease and may continue to occur or may even result in further damage. Particularly I'm thinking of cross-reactive antibodies to neural tissue, where you may indeed have totally eradicated the infection perhaps, and yet there is sort of bystander damage through mechanisms of molecular mimicry. And that, if one is, I think, in order to come to that conclusion, you really, I think, to be fair to the patient, you really have to give the patient a really reasonable trial of treatment with antibiotics. I don't think, a week or two of treatment and you don't see any response. I don't think, from what we know of the pathogenesis and the way in which people get better from Lyme disease, I think you have to give the patient a fair shake and really convince yourself and the patient that further antibiotic therapy is futile. And then you may move to other kinds of supportive therapies, a variety of kinds, and I think we have to, medical science has to develop methods of treatment that we may not even have at this point. I'm not sure exactly where to put this. I guess these are just different manifestations. Okay. New category, when you have not been able to garner any laboratory evidence, but you fulfill various manifestations. There's a history of prior good health, a defined onset of symptoms, and after thorough evaluation and being unable to establish an alternative diagnosis and a response to presumably to antibiotic therapy. Again, I think as we have better and better laboratory methods for diagnosis, including antigen detection methods, DNA detection methods, the Gunderson-Lyme test, if that proves to be a valid and useful technique, will also be another method that we can use. And I think probably eventually in the fullness of time we will have reliable methods, so it's not just a clinical diagnosis. And these are some of the modes of diagnosis that we have available to us and that are on the horizon. The Gunderson-Lyme test, I don't think is specifically mentioned. Isolation of the organism, I mean, that is the true gold standard, but it's a very elusive organism, and it's very difficult to isolate. But those few cases where it is isolated, I think, doesn't mean that it's rare. It just means that it's rare to be able to isolate it. And when you do isolate it, it can give you a clue what's going on with many other patients in whom you cannot get that level of proof that you would like to get. Okay, you got to rule out false positives, and I think it is very important to point out to patients that a positive Lyme serology in and of itself does not prove that a patient has Lyme disease, just as a negative Lyme serology does not prove that the person does not have Lyme disease. Okay, and I guess this question of endemic counties has already been addressed, and I think is no longer part of the case definition from the CDC. And that's about all I have to say. Anybody else want to make any comments? Anyone who was at the November meeting like to add anything besides what I have said? Okay, why don't we move on to the next